Hello, dear Professor Rosanna. Hello, dear colleagues. Today, I would like presentate my presentation according to diagnosis of angina. Okay. There is no conflict of interest regarding to this presentation. As we know, chronic coronary syndrome or angina pectoris affects likely in excess of 100 million adults worldwide. And there are currently 4.1 million deaths due to coronary artery diseases in Europe each year. And approximately in 50% situations, angina can be first sign of ischemic heart diseases. And it has been shown to double the risk of major cardiovascular events. Additionally, angina associated with reduced quality of life and high healthcare costs. There are some challenging factors now, and sometimes it's really challenging and difficult to make diagnosis of angina. Therefore, approximately 43% of patients they are remain under-recognized. And also 60% of angina patients are not receiving an optimal medical therapy. In Azerbaijan, we have made some surveys with collaboration World Health Organization and with collaboration European Preventive Cardiology Association. And we recognize some cardiovascular risk factors in our population. And according to this data, the percentage of current smokers among men was higher in the younger age group compared with elder age group. And also, I would like to emphasize that among women, there was a high incidence, low incidence of current smokers compared with male. And what about prevalence of arterial hypertension? The prevalence of arterial hypertension also is high in our population, and only 48% of all who had raised blood pressure or arterial hypertension took medication. And what about prevalence of dyslipidemia in Azerbaijan? A total of 26.9% of the population had a total cholesterol level equal or above 5 millimole liter, whereas 6% had a total cholesterol level of 6.2 millimole liter. And the percentage of respondents with raised total cholesterol and currently taking medication for high level of cholesterol was also low. And there was not significant difference in the mean level of HDL between males and females. And also, I would like to accentuate that among our population, actually, our population prefer consume red meat and they consume less vegetables and fruits, and also salt intake is very high among men compare women. And also we have estimated 10-year cardiovascular disease risk in Azerbaijan, and actually it was also very high among people aged 55 to 69 years. And also, yes, and according to the State Statistical Committee of Azerbaijan, cardiovascular diseases is a main cause of death. And according to the latest World Health Organization data, also shows that Azerbaijan is very high risk region where cardiovascular mortality rate is very high. As I emphasized that many coronary artery disease patients do not have epicardial coronary obstructions, but have angina or ischemia. And also many patients with coronary obstructions do not have angina or ischemia. Next slide, please. And there are some general approach according to diagnosis. If a patient has low or intermediate coronary artery disease risk, we should apply non-invasive diagnostic tools. Whereas if a patient has high risk, probability of high risk coronary lesion, it's reasonable to apply coronary invasive angiography to this patient. Next slide, please. And now I would like to introduce my clinical presentation. We have a patient, 51 years old. She's a woman, and she doesn't have arterial hypertension. She doesn't have diabetes. She's not smoker, but she has family history among parents and first-degree relatives. She has shortness of breath when walking uphill, climbing more than one flight, and under emotional stress. And her complaints continues over 2 months. How we should assess her? Next slide, please. First of all, I would like accentuate that she doesn't have any previous coronary artery diseases. That's why we apply score risk assessment in order to reveal her cardiovascular risk. And we reveal that her cardiovascular. Next, please. Her cardiovascular disease risk is very high. Next, please. Next. As I mentioned, she's 51 years old, and it means that she's now in menopause period. And we know that incidence of cardiovascular diseases increases continuously with age in women. And especially menopause is associated with vascular dysfunction, increased blood pressure, redistribution of body fat toward abdominal areas, which increases waist circumferences, and hyperlipidemia. Of these factors increases cardiovascular disease risk. Next slide, please. And according 2019 chronic coronary syndrome guidelines, as first step, we should assess her symptoms and perform clinical investigations. Next slide, please. We know that there are some kind of angina, and it can be a typical angina pain, it can be atypical angina or non-anginal chest pain. And among female, we more are encountered atypical angina than typical angina. Next slide, please. And studies published since 2015 have reported that the majority of patients suspected of having coronary artery diseases present with atypical or non-anginal chest pain, whereas only few presenting with typical angina. Next slide, please. And according to Canadian Cardiovascular Society grading of effort angina severity, next, our patient, as I mentioned, she has shortness of breath under emotional stress. Next, please. And also, next, please. And when walking uphill and climbing more than one flight, it means that she has angina with moderate exertion. And as second step, we should consider comorbidities and quality of life. As I mentioned before, our patient doesn't have any concomitant diseases which can increases her cardiovascular disease risk. And as a next step, we should perform ECG, biochemistry, echocardiography at rest, or chest X-ray in selected patients. Next slide, please. And ECG is recommended in all patients with chest pain without an obvious non-cardiac cause. Also, echocardiogram is recommended in all patients in order to exclude alternative causes of angina, for identification of regional wall motion abnormalities, measurement of LVEF for risk stratification purpose, and evaluation of our diastolic function. Next slide, please. And we performed ECG. This is her ECG. But I would like emphasize that when we perform ECG, she doesn't have any complaint. And also echocardiography was normal, full blood contest was normal. But if you pay attention to her lipid profile, you realize that her total cholesterol level, LDL cholesterol level, and triglyceride level increased, and HDL level decreased. Next slide, please. And according to chronic coronary syndrome guidelines, we know that there can be 6 clinical scenarios of chronic coronary syndromes. Next, and our patient, maybe she has suspected coronary artery diseases with stable angina symptoms or dyspnea. Next, or maybe our patient has suspected microvascular diseases or suspected vasospastic angina. Next. And what we should do as next step, exercise ECG, CT angiography, invasive coronary angiography for our patient. Next slide, please. And according to guidelines, as next step, we should assess pretest probability and clinical likelihood of coronary artery disease. Next slide, please. And according to age and her symptoms, next, please. Our patient is, next, please. Our patient is a light green shaded region, which denotes the group with pretest probability of coronary artery diseases between 5 to 15%, in which testing for diagnosis may be considered after assessing the overall clinical likelihood based on modifiers of pretest probability. Next slide, please. And there are determinants of clinical likelihood of coronary artery diseases, which can increase cardiovascular disease risk. And our patient has dyslipidemia, and also she has a family history of cardiovascular diseases. Next slide, please. And according to this determinants, there can be two scenarios. High clinical likelihood or low clinical likelihood, but our patient, I think, moderate clinical likelihood. That's why if you pay attention, you can see that coronary CT angiography seems reasonable diagnostic tool for our patient. Next slide, please. And if you compare previous guidelines with current chronic coronary syndrome guidelines, you recognize that exercise ECG for diagnosis of stable coronary artery diseases in patients with intermediate pretest probability, we can apply it in past. But now, sensitivity and specificity of exercise ECG, we know that it's very low. That's why it's not reasonable use it to rule in or to rule out coronary artery diseases. Next slide, please. And as a next step, if our patient has high clinical likelihood of obstructive coronary artery diseases, it's reasonable to apply invasive angiography with EFR and FFR measurement. But if a patient has intermediate clinical likelihood of obstructive coronary artery diseases, it's reasonable to apply coronary CT angiography. Next slide, please. And we know that CT angiography have some advantages, and we can rule out significant coronary artery diseases by CT angiography in patients with a low or intermediate probability. Also, low attenuation plaques identified on CT angiography were most frequently related to the presence of ischemia, regardless of severity of stenosis, according to next study. And CT angiography can also provide important prognostic information and may allow risk stratification and guide future therapy decisions in coronary artery disease patients. Also, CT angiography has gained broad acceptance as a non-invasive imaging tool with ability excluding coronary stenosis with strong negative predictive value. Next slide, please. And this is meta-analysis, which show that, next please, exercise ECG has inferior diagnostic performance compared with diagnostic imaging test and has limited power to rule in or to rule out obstructive coronary artery diseases, whereas CT angiography has a superior diagnostic performance to rule in or to rule out obstructive coronary artery diseases. Next slide, please. As a result of evidences, we perform CT angiography and we reveal subocclusive stenosis of mid-lat. Next slide, please. And according to this evidence, we performed invasive angiography as well. Next. And invasive coronary angiography revealed significant stenosis of mid-lat, and our patient actually has family history among both parents, and they had also a myocardial infarction when they was the same. They were the same ages. That's why we decided to perform PCI, as well as we prescribed medical treatment to this patient. Next slide, please. And due to guidelines, CT angiography is recommended as the initial test to diagnose coronary artery diseases in symptomatic patients in whom obstructive coronary artery diseases cannot be excluded by clinical assessment alone. Next slide, please. And the current European and American guidelines on the management of stable coronary artery diseases recommends that patients with intermediate pretest probability of significant coronary artery diseases should undergo non-invasive evaluation. Next slide, please. And in summary, we should assess the nature as well as origin of symptoms and the severity of symptoms, and we pay attention to duration of the symptoms. And we should pay attention to comorbidities and quality of life of each patient. Additionally, we should assess pretest probability and clinical likelihood of coronary artery diseases in evolution. And I would like emphasize that individualized approach is very essential, and we should select appropriate diagnostic test tool for each patient. Next. And I would like to conclude my presentation by quotes by Sir William Osler. Listen to your patient. He's telling you the diagnosis. The good physician treats the disease. The great physician treats the patient who has disease. And according to this quote, I can say that the good physician makes diagnosis the disease, but the great physician makes the diagnosis patient who has disease. Thank you very much for your attention.
Thank you, thank you very much, Dr. Ishanda. I mean, it's very, very good interrelation between the clinical case and the guidelines, and seeing how the guidelines should be applied. But also, we need to understand that guidelines give a guidance, and often they are they're drafted for rich countries, and of course, when we need to make the best of our availability of what is available. Now, in these patients, when you listened to her, what was your impression in terms of, I mean, were you convinced it was angina? It was, or what we call angina, because that is the other question I will have later.
Actually, I think that in to every patient, as I mentioned before, we should make individualized, perform individualized approach, because it's very crucial. Yes, there are a lot of diagnostic tools, and sometimes they are both, all of them are not available in some countries, or maybe in some medical centers. And I think that it's reasonable, as I mentioned, it's reasonable to pay attention to the origin of angina, to the duration, and also we should make differential diagnosis with other maybe with other diseases. Maybe it can be something muscular pain, or maybe a patient have some stomach problems or other things, and we should also think about these conditions. And I think that it's reasonable to use available, and also we should use appropriate diagnostic tool for each patient in order to reveal angina or coronary artery diseases.